Good morning, everybody. My name is Nihal Shakankiri. I am a professor of ophthalmology in Faculty of Medicine, University of Alexandria in Egypt. And I'm going to present a lecture about persistent fetal vasculature in children. I have no financial disclosure, and this lecture is only for educational purposes, and all the photos and the clinical cases and surgeries presented are the intellectual property of Alexandria University. It holds the exclusive copyright, and any unauthorized copying, distribution, utilization, or publishing is strictly prohibited. And as I told you, this is only for educational purposes. To start with, cases of congenital cataract, sometimes they are not simple congenital cataract. They are simply associated with what is called persistent fetal vasculature. During intrauterine life, the hyaloid artery emerges from the disc and goes forward around the lens. And then at birth, they are rudimentary. If any part persists after birth, this is called persistent fetal vasculature. There are 5 types of persistent fetal vasculature. If the anterior tunica vasculosa lentis persists, this is called persistent pupillary membrane. If the posterior tunica vasculosa persists, clinically it is termed persistent posterior fibrovascular sheath of the lens. If the only anterior part of the hyaloid artery persists, that is called Mittendorf dot. And if only the posterior part of the hyaloid artery persists, this is called Burmester papilla. However, if the hyaloid artery extending from the disc to the posterior surface of the lens persists, this is called persistent hyaloid artery. To start with, persistent fetal vasculature, the persistent pupillary membrane. Clinically, it appears like that, pigmented membrane. It's usually irregularly distributed like that, few strands extending 180 degrees or 360 degrees, and sometimes irregular like this. It may be associated with congenital cataract, thick membrane like this, and sometimes congenital cataract associated with thin pupillary membranes. Sometimes it is associated with cataract and also iris coloboma, and sometimes associated with congenital cataract and lenticular coloboma. Here, as you see, there is an iris coloboma and a bridging persistent pupillary membrane. Some cases of persistent pupillary membrane are associated with AC dysgenesis, as we see here, Peters anomaly. AC dysgenesis, can you see here again? This is the iridocorneal contact with the Peters anomaly extending nearly 180 degrees, and you can see the persistent pupillary membrane against red reflex, and they usually don't obstruct the visual axis. Some cases of persistent pupillary membrane are adherent to the anterior surface of the lens, and some cases are non-adherent. And some cases are partly non-adherent and partly adherent. Cases may be associated with pigmentation over the anterior surface of the lens. And sometimes not only pigmentation of the anterior surface of the lens. Look here at the back surface of the cornea. We will focus on the cornea. It is associated with pigmentation over the back surface of the cornea. The adherent membrane may be mild like that. It may be moderate and sometimes severe like this. And the pigmented area, as you see, may be densely pigmented, rounded, or irregular. It may be densely pigmented central area of pigmentation, sometimes light area of pigmentation, sometimes variable in both eyes. The size of the adherent area may be small and sometimes large. And sometimes totally obstruct the visual axis. Surgery is indicated in pigmented cases when it totally obstructs the visual axis like that in bright light. However, the non-adherent persistent pupillary membrane, they usually don't affect the vision, and the visual axis is somewhat clear. But sometimes when they lie in front of the pupillary area, especially in bright light, they obstruct the visual axis. And in these cases, surgery is indicated. You can see here the ghost vessels against red reflex. Surgery is simple. Through 2 corneal wounds and a micro scissors, usually 23 or 25 gauge, you can cut these membranes easily through 2 corneal wounds and then get it outside the eye to clear the visual axis. And then these 2 corneal wounds are sutured with 10-0 sutures. Even large adherent membrane can be peeled off the anterior surface of the lens. Here at conclusion of surgery. This is before and after surgery. This is before a very dense membrane and after clearing the visual axis and exposing the pupillary area. Some cases of persistent pupillary membranes are partly, you see strands here, and partly fibrotic. But if you look here with magnification, you can see the vasculature in the fibrotic part. Surgery is indicated in these cases when they obstruct the visual axis and there is diminution of vision. Again, it is simple surgery where you can cut easily the membrane and expose the pupillary area, and here before and at conclusion of surgery. Some cases of persistent pupillary membrane are only fibrotic and small, mimicking anterior polar cataract. As you see here, it looks like anterior polar cataract, but with magnification, you can see the iris strands of the persistent pupillary membrane, partly fibrotic, and these are tiny strands here. Sometimes this fibrotic membrane is adherent with a larger area of like iris tissue, but surgery is not indicated in these cases, but because usually they don't obstruct the visual axis. But sometimes the fibrotic persistent pupillary membrane may be large and obstruct the visual axis and cause diminution of vision. And in these cases, surgery is indicated. Surgery in these cases, it is very simple to peel off, again, these fibrotic membranes from the anterior surface of the lens. Any fibrotic membrane here, as in this case, can be peeled off so easily and pulled off the anterior surface of the lens and being cut to clear the visual axis. Some cases of fibrotic membrane are associated with strands of fibrosis, as you see here to the periphery here. There is a prominent Schwab's line, so it is associated with AC dysgenesis. And this prominent Schwab's line may be a small area or maybe extensive like this, extending 360 degrees. And these cases may cause undilatable pupil, as in this case, and sometimes shifting and drifting the pupil, correctopia, severe correctopia, obstructing the visual axis, sometimes with or without secondary glaucoma. In these cases, we have to clear the visual axis. So surgery is simply going with a micro scissors, 23 gauge, and performing a sort of a visual iridectomy. Here at conclusion of surgery, and there is an area of a small polar lenticular opacity. The same eye 1 year after surgery, the polar opacity is stationary and we have a beautiful clear visual axis. Some cases of persistent pupillary membrane are adherent to the anterior surface of the lens with a fibrous ring, either extending 180 or 360 degrees. Look here with magnification. This is the persistent pupillary membrane, and here the 180 degrees adhesion, and here a 360 degrees fibrotic ring. And if you look here, this is the edge of the dilated pupil. Sometimes this ring is central and sometimes eccentric. Here, before and after clearing the visual axis, and you can see the pupil dilates and constricts perfectly. This is before and after clearing the visual axis and exposing the pupillary area, and the pupil now can dilate perfectly. Some cases of membranes, they may show a sort of a diffuse iris tissue together with a white fibrous ring. This white fibrous ring may totally obstruct the visual axis like this, and associated with, again, AC dysgenesis, as here a prominent Schwartz line, and even associated with iridocorneal contact and secondary glaucoma. Even these membranes can be surgically removed here at time of surgery, cutting the membrane with micro scissors, and then making a multiple sphincterotomies here before and at conclusion of surgery. This is another case with diffuse iris tissue totally obstructing the visual axis. Here the membrane is cut easily, and you can see here even the edge of the pupil against red reflex, and there is here an iris coloboma. We cut the membrane and get it outside, and here at conclusion of surgery, this is before and after clearing the visual axis. Here another case before and at conclusion of surgery, and the pupil is perfectly exposed. This is a child with sensory exotropia due to a fibrotic persistent pupillary membrane, and this fibrotic membrane totally obstructs the visual axis in bright light. Here, cutting the membrane and peeling it off the surface of the lens, here 1 day after surgery. This is before and after clearing the visual axis. Here, after surgery, with good amblyopia therapy, straight eyes were attained. The second type of persistent fetal vasculature is the Mittendorf dot. It is the anterior part of the hyaloid artery inserting to the back surface of the lens, only the anterior part of the hyaloid artery. In these cases, usually they don't affect the vision, and they just related to the posterior pole of the lens. But in some cases, this is a Mittendorf dot associated with a fibrosis of the posterior capsule. And some cases like that, can you see this is the anterior part of the hyaloid artery associated with a fibrotic plaque of the posterior capsule, and here affecting the vision. In these cases, can you see here? This is the fibrotic plaque of the posterior capsule. During surgery, we can perform posterior capsular access around this plaque and leave it in place. We go with a cutter and we eat it up. Can you see? This is the hyaloid artery, the anterior part of the hyaloid artery. We eat it with a cutter, perform anterior vitrectomy. Now it's like a simple case of congenital cataract where we can inject the intraocular lens inside the capsular bag between the two rhexis. The third type is persistent hyaloid artery. Persistent hyaloid artery, it means the hyaloid artery extending from the optic disc up till the posterior surface of the lens, presenting clinically as a posterior polar opacity related to the posterior pole of the lens. And from this opacity, you can see the hyaloid artery going backward. And here seen with the red cam, this is the polar opacity and hyaloid artery extending to the optic disc. The whole hyaloid artery is present. Different sizes of hyaloid artery may be seen. It may be small and tiny like this and not indicated for surgery, or may be extensive and bulky and vascular like this case. During surgery, can you see? It's a very thick hyaloid artery and a huge posterior capsular plaque. Or it may be a very small hyaloid artery that accidentally discovered with the case of a congenital cataract and expected a posterior capsular defect, congenital posterior capsular defect. And look here to this hyaloid artery. It's a very tiny hyaloid artery, empty hyaloid artery that was actually discovered accidentally during cataract surgery. Some cases are associated with congenital tent-shaped retinal detachment. The axial length in these cases may be normal or may be microphthalmic. Sometimes it is associated with severe microphthalmia and extensive like this, and surgery actually it's not indicated for in these cases because the visual prognosis is extremely poor. And some cases are associated even with atrophia bulbi. They are so extensive with no PL vision, and surgery is not indicated in these cases. Let's see how to proceed with surgery. Cases with a hyaloid artery where it inserts to the periphery here, they are thin hyaloid artery, and the insertion is in the peripheral part of the lens. Usually these cases are not indicated for surgery, but you have to go for refraction because these cases may be associated with lenticular astigmatism that has to be corrected by glasses. But some cases of peripheral insertion of the hyaloid artery may be associated with a congenital cataract and associated with a corrugation of the posterior capsule and associated even with lenticular coloboma. And in these cases, they are associated with irregular astigmatism that is not amenable to be corrected by glasses, and surgery is indicated in these cases. We can go for the conventional surgery, anterior rexus 5 millimeter, irrigation aspiration, and then we go for straightforward posterior capsular rexus, and then during vitrectomy, we can eat up the hyaloid artery and just leave the anterior stump here, and we can inject the intraocular lens between the anterior and posterior capsular rexus. Cases where the hyaloid artery inserts in the posterior pole, in the central part of the posterior capsule here, it shows a small polar opacity with irradiating fibrosis or larger area of radiating fibrosis. How to proceed in these cases? After irrigation aspiration, we usually perform posterior capsular rexus around the insertion of the hyaloid artery, and then we go to eat up the hyaloid artery with the cutter and perform anterior vitrectomy, and we inject intraocular lens between the two rexes. But sometimes the insertion of the hyaloid artery is eccentric. In these cases, we go for, after irrigation aspiration, the posterior capsular rexus is partly done with the rexus forceps and partly done with the scissors. And then we complete the surgery, we perform anterior vitrectomy, and we inject the IOL inside the capsular bag. There are variability of the insertion of the hyaloid artery. Sometimes it inserts into the posterior capsule and present with a cup like that, mimicking posterior lenticonus. But usually in these cases where it looks like a cup or a posterior lenticonus, you see vascularization in the base of the cup. So it confirms the presence of persistent fetal vasculature. You can see here vasculature in the base of this cup. Sometimes it dips into the posterior capsule and shows a whorly opacification or a pearly opacification of the posterior capsule. You can see here the shadow of the hyaloid artery. How to perform surgery in these cases? After irrigation aspiration, usually there is a mild fibrosis of the posterior capsule where we can go for the conventional posterior rexus with the rexus forceps. You can see here the hyaloid artery, and then leave the posterior capsule in place. Don't pull. Then we go with the cutter to eat up the hyaloid artery. You can see here this is part of the hyaloid artery, perform anterior vitrectomy, and now we can inject the intraocular lens inside the capsular bag. Or we can go directly with the scissors. We cut the posterior capsule, we make a 180 degrees like that cut, and then with a cutter, we can go and trim the posterior capsule into a 4 millimeter capsular opening, perform anterior vitrectomy, and inject the IOL inside the capsular bag between the anterior and posterior rexes. But take care. The insertion of the hyaloid artery into the back surface of the lens may show fibrosis like that. And this fibrosis may be radiating fibrosis on the back surface of the posterior capsule. Here, this radiating fibrosis will make posterior rexus difficult. So look here, we will focus now on the posterior capsule. When focusing on the posterior capsule, you can see this radiating fibrosis. In some cases, we can perform the anterior rhexis, and then we can perform the posterior capsulorhexis, totally inseparable from this fibrosis. And then we go with the cutter and eat up the fibrosis and the hyaloid artery, and then in between the two rhexes, we can inject intraocular lens. But this is not possible in all cases. Some cases of this radiating fibrosis, what's going to happen? Can you see these are radiating fibrosis on the back surface of the posterior capsule? After irrigation aspiration and during cutting the posterior capsule, they tear up easily. So what to do in these cases? We remove the whole posterior capsule with a cutter, and then we inject a multi-piece intraocular lens in sulcus and perform optic capture technique. So the key of success in these cases is the anterior capsulorhexis. Look, this is another case. This is the insertion of the hyaloid artery. Now focus in this area. We will focus on the posterior capsule. There is a corrugation which is totally away from the insertion of the hyaloid artery. Look here with magnification. This is the insertion of the hyaloid artery, and these are radiating fibrosis behind the posterior capsule. And look to this area. This is corrugation of the posterior capsule. In these cases, it is very difficult to perform the posterior rhexis. So as I said, the key of success is the 5 millimeter anterior capsulorhexis. So when you go to open the posterior capsule, even if it tears up like this, no problem. We remove the posterior capsule, perform anterior vitrectomy, inject a multi-piece in sulcus, and perform optic capture technique. And this is how optic capture technique appears after surgery, a few months and here a few years after surgery, having all advantages of capsular IOL. Some cases may be associated with intralenticular hemorrhage. And these cases, usually there is a fibrotic plaque like this, or a hemorrhagic plaque. You can see hemorrhage inside the plaque. This is another case of intralenticular hemorrhage, and you can see hemorrhage inside the posterior capsular plaque. Or you can see hemorrhage around the posterior capsular plaque. And sometimes you see a localized cortical hemorrhage, and this localized cortical hemorrhage is actually coming from this cup insertion of the hyaloid artery into the posterior capsule. How to proceed surgically in these cases? After irrigation aspiration, you can see even staining of the cortex. And during cutting of the posterior capsule, microhemorrhages may occur from these vasculature, but they are usually self-limited, and you can perform the vitrectomy and inject the intraocular lens inside the capsular bag. Here on the case with a posterior capsular plaque, and it is hemorrhagic. How to proceed in these cases? We can usually peel off this posterior capsular plaque, hold it with a forceps, and then cut it off the posterior capsule. And then we cut the posterior capsule. And then, can you see here, this is the hyaloid artery. And then we trim with a cutter to the desired size, and here at conclusion of surgery. This is another case with a hemorrhagic plaque. After peeling off the plaque, we peel it off the posterior capsule. You can see here staining the back surface of the capsular plaque from a tiny patent hyaloid artery. Here we can perform posterior capsulorhexis in the conventional way, and then we eat up the hyaloid artery during vitrectomy. And here at conclusion of surgery. This is the case of cortical hemorrhage, usually aspirated during irrigation aspiration, and then around the cup we go with the scissors to cut the posterior capsule, and then we go with a vitrectomy to eat up the hyaloid artery and trim the posterior capsule, and here at conclusion of surgery. Some cases of hyaloid artery Can you see this is the tiny hyaloid artery, thin hyaloid artery, continue over the back surface of the lens. It may be here. Can you look? This is the artery here with magnification. You can even see blood trickling in this artery. It may be single, like this, or maybe double, or maybe multiple arteries extending to the back surface of the posterior capsule, or may extend 360 degrees. During surgery, you can peel off again. This is the plaque, and we peel it off. We can see here the hyaloid artery and the extension of the hyaloid artery on the back surface of the posterior capsule. We can peel off the plaque here, and here after peeling the plaque, we can perform posterior rhexis anterior vitrectomy, here at conclusion of surgery. Or we can go directly with the scissors and cut the posterior capsule and trim it with a cutter, and here at conclusion of surgery. In these cases, after irrigation aspiration, spontaneous hemorrhage may occur. We can inject viscoelastic, and usually it is self-limited. And you see here, this is the hyaloid artery. Here, after peeling off the posterior capsular plaque, you can see here the hyaloid artery and the extension of the hyaloid artery. And then hold it with a forceps, and then go with the scissors to cut the plaque. Can you see this is the tiny hyaloid artery? And then here, posterior rhexis anterior vitrectomy, and here at conclusion of surgery. These cases, during cutting the posterior capsule, it may show bleeding, but usually, again, this bleeding is self-limited during vitrectomy. We trim the posterior capsule, perform anterior vitrectomy, and here at conclusion of surgery. Some cases of hyaloid artery may continue even over the anterior surface of the iris. Look here, this is a continuation of the hyaloid artery over the anterior surface of the iris. Usually, when opening the anterior capsule, the cornea with an MVR, they blanches, they fade away. Take care that these microvasculature over the anterior surface of the lens, after irrigation aspiration, they show spontaneous bleeding from this vasculature. And sometimes after irrigation aspiration and during cutting the posterior capsule, they present with hemorrhages like that. But again, it is self-limited, and here at conclusion of surgery. On the contrary, some cases are the membrane or the insertion of the hyaloid artery. You see it is mainly fibrotic. The posterior capsule is mainly fibrotic. More fibrosis than vasculature. In these cases, after irrigation aspiration, we cut the posterior capsule and then trim here with a cutter. And you can see here, this is the hyaloid artery. Again, this is the hyaloid artery during vitrectomy, and here at conclusion of surgery. In this fibrotic cases, we can, after cutting the posterior capsule and after performing vitrectomy, in some cases we can perform primary IOL implantation inside the capsular bag. And here, years after surgery, despite the fibrosis, we have a clear visual access. Some cases, there is no vascularization. It's only fibrosis, either mild fibrosis or very dense fibrosis of the posterior capsule. And these cases where it's only fibrosis, there is no problem here. We can cut the posterior capsule with the micro scissors and then trim with a cutter to the desired size, posterior, perform anterior vitrectomy, and here at conclusion of surgery. Some cases of hyaloid artery are associated with a congenital posterior capsular defect. This is the hyaloid artery, and this is the posterior capsular defect. It may be small, it may be moderate in size, and sometimes it is large. And you can see here the hyaloid artery. Sometimes it is central, and sometimes this defect is eccentric. Sometimes the defect here in the posterior capsule may be seen against a bright red reflex, and sometimes this defect is actually hidden behind a total cataract. Do you see here with the magnification? This is a total cataract. But look here, this is a fibrosis and vascularization, and this defect is hidden under the total cataract. During surgery, we trim the posterior capsule, perform anterior vitrectomy, and here at conclusion of surgery. And in some cases, we can implant, if the age permits, we can implant intraocular lens inside the capsular bag. This is a small defect. We perform cutting of the posterior capsule around the defect, and then we go and trim and eat the hyaloid artery with a cutter, and we can inject intraocular lens inside the capsular bag. In cases where we have a moderate defect, a moderate size defect within the vicinity of the anterior capsular axis, still we can perform a large posterior capsular axis, perform vitrectomy, and inject the IOL inside the capsular bag despite having a large posterior capsular axis. But cases where we expect that a large posterior capsular defect, as in this case, and this is the shadow of the hyaloid artery, we remove everything. We clear the visual axis, and this is the hyaloid artery here. We remove the whole posterior capsule, and as long as we have a 5 millimeter anterior axis, we can inject the multi-piece intraocular lens inside the capsular bag and push the optic behind the anterior axis and perform optic capture technique. And here how it appears after surgery, as we presented before. Prominent ciliary processes. Some cases of a hyaloid artery are actually associated with prominent ciliary processes that may extend 45 degrees or 180 degrees or even 360 degrees. Some cases are gigantic prominence of ciliary processes. These cases may be a solitary large, gigantic ciliary processes, or multiple or even extensive like this. During surgery and after irrigation aspiration and during cutting, can you see here with the magnification? There is huge ciliary processes. Usually they are rudimentary, and you can cut the posterior capsule together with these ciliary processes and they don't bleed. And here they are trimmed with a cutter, and here at conclusion of surgery. This is another case after irrigation aspiration and during vitrectomy. This is the hyaloid artery. Here after performing vitrectomy and at conclusion of surgery. Few months later, at time of secondary IOL implantation, this turned into a fibrous ring where we can inject secondary intraocular lens in sulcus. And here we have a beautiful, clear visual axis. And in some cases, after performing anterior vitrectomy, we can implant primarily the IOL inside the capsular bag between the anterior and posterior plexus. The other type of persistent fetal vasculature, the persistent posterior fibrovascular sheath of the lens, which is what? It's persistent tunica, posterior tunica vasculosa lentis. In these cases, it is a fibrosis together with a vascularization related to the back surface of the lens. These cases may involve the whole posterior capsule or may extend just a sectorial part of the posterior capsule. It may be circular, either small or large, or whole posterior capsule with variable degrees of fibrosis. It may be associated with variable degrees of vascularization, maybe thin vasculature, even thick vasculature. And even intralenticular hemorrhage may be present, usually associated with lens anomalies. Like what? Like totally irregular lenses, maybe microphakia, microspherophakia, lenticular coloboma, many lenticular anomalies in the shape of the lens. Usually you see the equator of the lens comes in contact with the prominence of ciliary processes. Can you see here? This is a small spherical lens, and these are the ciliary processes. Cortex may be liquefied like this, or may be partially absorbed, or lenticular matter may be totally absorbed, presenting with a membranous cataract that you can even see the fibrosis, the fibrovascular membrane, even through the lens. And sometimes the lens is a small globular structure over a fibrovascular membrane. Let us see how to proceed in these cases. After irrigation aspiration, we go and cut this fibrotic membrane, half a circle like this, and then we go with a cutter and trim into a circular opening. But we go in between this fibrotic ring, in between the ciliary processes, and make radial tears. And in cases, this is another case, after irrigation aspiration and after cutting the fibrous ring, we have here transparent capsule, but we have here a fibrotic capsule and prominence of ciliary processes. We go with the micro scissors in between the ciliary processes and make radial tears. And here at conclusion of surgery. But in cases where we have prominence of ciliary processes extending 360 degrees, after cutting the membrane and after trimming with the cutter, we don't leave it like this. We go with a radial cuts 360 degrees, and then we perform the anterior vitrectomy, and here at conclusion of surgery. Why? Why do we do this? Why we don't leave it like this as a clear fibrous ring for future secondary IOL? If you leave it like that, in 100% of cases, capsular phimosis will occur and secondary cataract will occur, and you will have to go on with the secondary surgery in order to clear the visual axis. Not only this will happen, if you leave it like this with a fibrous ring and prominence of the ciliary processes, not only capsular phimosis will occur in the future, but pulling over the ciliary processes may lead to even atrophy of the eye. So you have to go quickly and then cut the capsular phimosis and clear the visual axis and relieve the traction over the ciliary processes. Some cases are mixed between hyaloid artery and posterior fibrovascular sheath of the lens, two types together. You see here the hyaloid artery extending from the disc to the back surface of the lens, and you can see here thick membranes. So you have to go for ultrasound and you have to go for UBM in order to decide whether to go for surgery or not. Because as I told you, some cases, extensive thick membrane, hyaloid artery, and very short eyes. These cases will not benefit from surgery. During surgery, after irrigation aspiration, this is a posterior fibrovascular sheath of the lens. But after cutting of the membrane and eating up with the cutter, it is associated here. Look, this is a hyaloid artery. This is very evident here. This is a hyaloid artery too. In these cases, we can leave the hyaloid artery obstructed by a small part of fibrosis, and then after trimming into a circular fibrotic ring, we go again in between the ciliary processes with the micro scissors, and here at conclusion of surgery. This is another case. Can you see these are the ciliary processes hidden under the iris, here with magnification. After cutting, we cut and then trim with the cutter. Here, it is associated with a hyaloid artery. It is evident here This is the hyaloid artery eating up and then leaving it obstructed by a small fibrotic area like this. Here, after performing anterior vitrectomy and then going with radial cuts, and here at the conclusion of surgery. This is another case with dilatation. You can see here the ciliary processes. These cases, actually, you cannot perform anterior capsular access. Useless to go for anterior capsular access. The lens is usually globular. We hold the lens with a microforceps, and then we cut the anterior capsule with the scissors. And then after irrigation aspiration, we remove actually the whole anterior capsule. After irrigation aspiration, penetrate the membrane, go with cutting with the scissors, hold the membrane, go from the other port, cut the membrane, and then again, you can see here the hyaloid artery, eat it up with cutter here. You see this is the hyaloid artery obstructed with a small area of fibrosis after anterior vitrectomy, and then going with the radial cuts here to prevent capsular phimosis. Anterior vitrectomy, and here at conclusion of surgery. This is another case, totally irregular and globular lens, penetrating the lens with a cutter, holding the lens with a forceps, cutting the anterior capsule and removing the whole anterior capsule, irrigation aspiration, cutting the membrane, and then during capsulectomy, you can see the shadow of the hyaloid artery. So many cases actually are associated with both posterior fibrovascular sheath of the lens and persistent hyaloid artery here after trimming. Now we have a 360 degrees ciliary processes. So we have to go for these radial cuts, 360 degrees anterior vitrectomy. This is another case, small globular lens here with magnification, and you can see here the ciliary processes. After irrigation aspiration and after removing the whole capsular bag, you leave only the posterior capsule and this fibrovascular membrane. Penetrate the fibrosis, cut. Here, cutting the fibrosis, and you can see the shadow of the hyaloid artery. Cutting, and now it's time to go with the cutter, remove the posterior capsule and the fibrosis. You see here the hyaloid artery. You can trim it regularly, and then here we leave an area of fibrosis obstructing the hyaloid artery. And then we go with the radial cuts, and here at conclusion of surgery. Sometimes the three types are present together: persistent pupillary membrane, persistent hyaloid artery, and posterior fibrovascular sheath of the lens. This is persistent pupillary membrane, and usually the membrane, if it is dense and severe, it causes irregularities of the pupil. It may distort the pupil like this or prevent good dilatation of the pupil. And you can even see that the ciliary processes within the pupillary area. Sometimes persistent pupillary, in cases of persistent fetal vasculature, you can see here the fibrosis and the vascularization. We will focus now on the anterior surface of the lens. Can you see? This is a persistent pupillary membrane, which is vascular here, and it may extend towards the angle, mimicking actually AC dysgenesis. And it is, in fact, a persistent fetal vasculature. Sometimes only the equatorial part of the persistent fetal vasculature is present, and usually it indents the equator of the lens. Look here, these are the fibrosis remnants, and these are ghost vessels. It looks like a lenticular coloboma. Some cases of persistent fetal vasculature may be associated with undilatable pupil. Due to what? If it is due to atrophy of the sphincter pupillae, during surgery, we will have to go for multiple sphincterotomies. And here, after irrigation aspiration, you can see here the shadow of the hyaloid artery. we cut the posterior capsule and we eat it up with a cutter. This is the hyaloid artery. And here at conclusion of surgery. Sometimes persistent fetal vasculature is accidentally discovered. This is a membranous cataract, fibrosis of the anterior capsule. After cutting the anterior capsule and after irrigation aspiration, there is fibrosis of the posterior capsule. And after cutting the posterior capsule and during here capsulectomy, you can see here the shadow of the hyaloid artery that was not discovered before surgery or misdiagnosed before surgery. And here after vitrectomy, and we do it like a conventional case of congenital cataract, and here at conclusion of surgery. This is another case of donut-like cataract. The anterior and posterior capsule are adherent in the center of the lens. After irrigation aspiration and during cutting of the posterior capsule, this is the shadow of the hyaloid artery. Can you see this is the shadow of an empty hyaloid artery? Here, it is seen here, focusing on the hyaloid artery. This is an empty hyaloid artery, and then we eat it up with the cutter and here at conclusion of surgery. Some cases, again, accidentally discovered when performing a membranous congenital cataract with a congenital posterior capsular defect. This was actually a congenital cataract. Can you see this shadow? This shadow is a congenital posterior capsular defect. Let's see. The first eye, this is the edge of a posterior capsular defect. After dilatation, this is a congenital posterior capsular defect. After irrigation aspiration, can you see? This is a congenital posterior capsular defect with fibrosis of the anterior vitreous face. This is the shadow of the defect. Here, performing vitrectomy, and here at conclusion of surgery. While performing the second eye, here with magnification, this is the edge of the defect. We are expecting to have a congenital posterior capsular defect. We did anterior capsulorhexis. Can you see this is again the shadow of the defect? After irrigation aspiration, this is the congenital posterior capsular defect. But what is this? This is a shadow of a hyaloid artery, a persistent hyaloid artery that was accidentally discovered during cataract surgery. Then we perform the conventional anterior vitrectomy and here at conclusion of surgery. It may be associated with keratolenticular adhesion. There is iris adherent to the back surface of the lens. Here, the iris is totally adherent to the back surface of the lens. Here, irregular areas of iris adherent to the back surface of the lens, together with the lens. Let's see. This is a simple case. Congenital cataract, persistent fetal vasculature, and iridocorneal contact, and even corneolenticular adhesion. After releasing the adhesion, we perform surgery in the conventional way, and then we go with the radial cuts here and here at conclusion of surgery. This is another case. The iris is totally adherent to the back surface of the lens. Here, after releasing the synechia, you can see here the lens, and you can see here the persistent fetal vasculature, and during vitrectomy, clearing the visual axis and at conclusion of surgery, and this is the shadow relieving the area of adhesion that was present. This is another case with extensive keratolenticular and iridocorneal contact. After sphincterotomies, we were able to clear the visual axis. Here before and after lensectomy, or at conclusion of surgery after clearing the visual axis. In cases where we go for lens surgery only, secondary IOL implantation. Let's see. This is a case of persistent fetal vasculature, persistent pupillary membrane, here with magnification, multiple sphincterotomies, after irrigation aspiration with prominence of ciliary processes, cutting the ciliary processes, performing vitrectomy, and here at conclusion of surgery. Few months later, there is a beautiful fibrous ring where we can inject a multi-piece intraocular lens in sulcus. Here before surgery, and here after secondary IOL implantation with clear visual access. This is an eye years after surgery with secondary IOL implantation in sulcus. You can see the fibrotic ring and you can see clearly the ciliary processes. And here again, thread reflex with clear visual access, and these are the ciliary processes. This is a final baby with a congenital cataract and persistent fetal vasculature and heterochromia. Here with magnification, this is his surgery. At conclusion of surgery, immediately after surgery, fitted with aphakic glasses. Few months later, straight eyes, time for secondary IOL implantation. Here, at time of secondary IOL implantation, dilating the pupil, you can see the fibrous ring, and you can see here the ciliary processes, injecting a multi-piece in sulcus, and you can see here clearly the ciliary processes, here at conclusion of surgery. After secondary IOL implantation with good amblyopia therapy, 4 years after surgery, straight eyes, 10 years after surgery, still maintaining straight eyes but develop myopic shift. This at time of secondary IOL implantation, years after surgery is the same eye, but there is more fibrosis. So we decided to go for an IOL exchange. Here at time of IOL exchange, dilatation of the pupil. You can see here the fibrous ring and the prominence of ciliary processes. It is possible to dial the intraocular lens inside the anterior chamber and then hold the IOL with a microforceps from the side port. With the long Van scissors, we cut the IOL into two, get one half outside the eye, the other outside the eye, and it is possible to re-implant a secondary multi-piece inside the eye. And now, this baby, 17 years after surgery, after cataract surgery, secondary IOL implantation, and IOL exchange, still maintaining straight eyes. This is another child 4 years after surgery with heterochromia and persistent fetal vasculature, maintaining straight eyes in the left eye. 6 years after surgery, and here 10 years after surgery. This is the fibrosis, and this is the ciliary processes, clear visual access, and still maintaining straight eyes. So finally, to conclude, we can go for surgery despite the extensive pathology that may be present. We can attain clear visual access in these cases. Despite the presence of fibrous ring and prominence of the ciliary processes, again, we can have beautiful clear visual access. This eye, 20 years after surgery, you can see here the prominence of the ciliary processes and a multi-piece inside the capsular bag, extensive fibrosis, extensive sommering ring. And despite of this, we can still attain clear visual access in these cases. And to sum up, persistent hyaloid artery is only one type of persistent fetal vasculature. There are other types as we did present. Some cases are operable and some inoperable, and they have a poor visual prognosis. So you have to go for a good selection of cases for surgery. It is very important in order to achieve good visual access, good visual outcome. And don't forget that these cases are unilateral cases. You fit the babies, or actually we fit the babies here in Alexandria University in Egypt with unilateral aphakic glasses, which are ultra-thin high-definition glasses. And then we go for a very good amblyopia therapy in these cases, because these cases, as I said, these are unilateral cases. In order to attain straight eyes, despite fitting them with unilateral aphakic glasses, here attaining straight eyes, until it is possible to implant secondary intraocular lens in these cases in order to have beautiful surgery and clear visual access and prevent blindness in these children. And thank you very much for your kind attention. We're going to see some question here. Can the persistent pupillary membrane fibrosis adherent to the anterior capsule and cause defect in the anterior capsule during peeling? No, it's very simple. And as I said, it is possible to peel it off if you have the experience to peel it off. It doesn't carry the risk of, but you have to be, of course, trained for such cases. What is the risk of vitreous hemorrhage with surgical intervention removing the hyaloid artery in this patient? Well, as I told you, the majority of the cases, these cases are self-limited. As you see, I'm very selective in the cases. I select the cases with good prognosis and not the extensive one with extensive vasculature, because usually they carry poor prognosis, and the hemorrhage is usually self-limited. And you can use, in these cases, or if you're afraid of hemorrhage, you can use intraocular diathermy in these cases. Can the persistent hyaloid artery lead to vitreous hemorrhage? Yes, definitely. If you choose the wrong patient to operate very vascular hyaloid artery, and in these cases, as I said, you have to use the intraocular diathermy. What are the indications for surgery if the patient presents with anterior synechia at 17 years old? Does it worth it to go for surgery? Well, actually, I go for surgery, even the age is 17. Definitely, these eyes will be amblyopic, but at least I would give it a try. What about the vascularized fetal vasculature? How do you perform posterior access? We said I go with the scissors. To perform this fibrovascular membranes with scissors. If I have a localized posterior capsular fibrosis, I go with the rexus around this fibrosis. But if it is extensive, I go with the scissors and the cutter. Do you use endocotery? Yes. Any complications? Of course, there are complications may occur, the least of which is secondary glaucoma and sometimes retinal detachment. So you have to be trained performing these cases. Not anyone can perform persistent fetal vasculature. Yes, we can implant intraocular lens in some cases. Some cases of microphthalmia less than corneal diameter, less than 10 millimeter, we can't implant. We can implant if the corneal diameter is 10 millimeter or more. If we have a sulcus, sometimes there is extensive prominence of the ciliary processes preventing good implantation in sulcus. And I implant at the age of 1. I used unilateral aphakic glasses, ultra-thin high-definition glasses until the age of 1 year, and then I implant secondary IOL in sulcus. So I think in the final, is there any special consideration for heterochromia? No, it is just associated with the persistent fetal vasculature. Is it associated with syndromes? Yes, sometimes in rare circumstances when the persistent fetal vasculature is bilateral, it may be associated with what is called Dandy-Walker syndrome. YAC? No, we can't. We can't perform YAC laser capsulotomy in these cases or in children. I prefer to open the posterior capsule during surgery. We can never leave the posterior capsule intact in these cases. Do you use anti-VEGF? No, rarely I don't use because I don't perform extensive persistent fetal vasculature. Now we finished the majority of cases, and we're gonna conclude the session. I hope it was of benefit to you, and thank you very much for your kind attention.